Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and I am joined today by Sujoy Menon, our chairperson for the Department of Radiology at Richmond University Medical Center. Through RUMC Connections, you'll meet the doctors, nurses, and medical professionals that make our hospital thrive. We'll provide you with some useful information about your own health and explore the latest medical news and hopefully get you answers to some of your own health-related questions. At RUMC, the Vascular Interventional Radiology Department performs approximately 2,000 procedures a year. Our board-certified and board-qualified radiologists offer various imaging modalities with advanced subspecialty fellowship training in their areas of expertise. As the recipient of the Joint Commission's Gold Seal of Approval for Quality and Patient Safety, we utilize only state-of-the-art equipment. We offer several different types of imaging modalities to diagnose and treat many diseases. These procedures give us a visual representation of what is going on inside the body in order to make a proper diagnosis and set up a treatment plan. So thank you, Dr. Menon, for joining us today.
You're welcome.
You are our first radiology guest.
Thank you.
And Dr. Menon has graduated from Rutgers UMDNJ Robert Wood Johnson Medical School and did a residency in Diagnostic Radiology at Beth Israel Mount Sinai in New York City. Dr. Menon completed a fellowship in Vascular and Interventional Radiology at Beth Israel Mount Sinai in New York City. Dr. Menon's areas of expertise include interventional oncology, uterine fibroid embolization, and other minimally invasive procedures. He treats spider veins and venous reflux disease in the legs using cutting-edge non-surgical techniques and offers targeted arthroscopic guided joint treatments with biologics. He specializes in complex pain management-related interventions of the spine, including steroid injections, nerve blocks, ablations, vertebral fracture stabilization, and more. So we are going to discuss interventional and diagnostic radiology today. Could you please discuss a little bit what exactly is interventional radiology?
Sure. Interventional radiology is a subspecialty of radiology as a specialty. Which entails taking minimally invasive procedures, minimally invasive techniques in reaching different organs of the body and delivering targeted treatments. We do biopsies this way. We stop bleeding in trauma patients this way. So we use little incisions, like a few millimeter incisions, and we enter your blood vessels, and using catheters and wires, we get to these organs and we deliver treatments to these organs. So it's a minimally invasive technique of getting to the organs, and this leads to quicker recovery, this leads to quicker treatments, and this also leads to better patient outcomes. So that's what interventional radiology is. And I sometimes explain to my parents the way I do it is what the cardiology does for the heart. We sort of kind of in a loosely speaking manner do the same thing for the rest of the body, except the brain.
Okay.
The brain is reserved for the neurosurgeons and the neurointerventionalists.
Got it. So it sounds like, being that you work with all the organs, all the veins, that you're working with a lot of different types of doctors as well.
Yes. So we are the consultants to consultants. So we are the doctors. Our main clients are physicians, whose clients obviously are the patients. At the end of the day, we do serve patients, all of us together, but we, particularly interventional radiologists and diagnostic radiologists, we work with a pool of different types of physicians. So we are always working in multidisciplinary groups.
Okay.
Not only physicians, we work with NPs, we work with nurses, we work with the entire healthcare team that serves patients.
Wow, so a big teamwork job.
Yes.
Okay. Now, how does interventional radiology differ from diagnostic radiology?
Right. So interventional radiology, as the name implies, is intervention. Okay. So in diagnostic radiology, we take images. We use different modalities to take images. CTs, MRIs, ultrasound, plain radiographs. They're all taken when the patient is under essentially a camera. We take the patient's images and a diagnostic radiology interpret those images, whether there is a fracture, whether there is a tumor, whether there is bleeding or not. Now, interventional radiologists take that information and again use some of the similar modalities like X-rays and CTs, and then target those areas which are pathologic and try to provide treatment to those areas. So we do the intervention part, the diagnostic radiologists do the interpretation part.
Okay.
So that's the difference.
So they go hand in hand.
They absolutely go hand in hand. All the interventional radiologists are essentially diagnostic radiologists also.
Okay.
Our hospital now has 3 board-certified, fellowship-trained interventional radiologists who also serve as diagnostic radiologists. So we are actually, we are very blessed to have all 3 interventional radiologists in our team, and they have been instrumental in taking our department to the next level.
Absolutely.
Working with multiple different teams of physicians in their subspecialties.
Okay. What is traditional radiology by comparison?
So traditional radiology is diagnostic radiology.
Okay.
And interventional radiology has been around for quite some time. So it's also, I would say, traditional radiology.
Okay.
But those two differ in the way that we discussed before. One does interpretation, the other one uses this interpretation and then uses radiologic modalities to provide treatment.
Got it. Okay. Now, how is interventional radiology used as a treatment option?
Right. So interventional radiology actually, like I said, we touch many different organs. We touch the lungs, we touch the kidneys, the liver, spleen, we touch the bones, we touch multiple different organs. Depending upon what the pathology is, let's say, for instance, I'll give you 2 examples. Number one is, let's say there is a nodule in a patient's lung, and this was discovered during a lung screening process, which we provide at RUMC. The lung screeners are basically a low-dose CT scan that the patient undergoes. And in that low-dose CT scan, we look for early signs of cancer. Let's say there is a small lung nodule which is suspicious of being a cancer. As we all know, the earlier the detection of cancer, the higher the chances of cure. So this is in that vein of thinking. If you see a little nodule in the lung, the interventional radiologist is consulted. The interventional radiology attending takes a look at the CT scan and then decides whether this is a safe for percutaneous biopsy. By percutaneous means going from the skin. Cutaneous means skin, right? So going from the skin. And then if that is the case, the patient is called in the hospital. The patient undergoes the procedure. The procedure is taking a small needle, essentially the size of the needle that goes into the veins when you go to the doctor's office. And we're using CT scan, we go into the little lung nodule, take a few samples of it, and then give it to the pathologist who makes the final diagnosis. If this is cancer, you have found out and discovered the cancer very early on. Then we talk to the oncologist, we talk to the surgeons and see what is the next best thing. If it is not cancer, then you know that you're good, and then you go on to the next stage of the cancer screening.
Okay.
So that's an example. Another example is, let's say, patient has an accident and has a bleed somewhere.
Yeah.
We can use catheters and wires to reach that organ and stop that bleeding.
Wow.
So interventional radiology does serve in many different ways, and hence we touch many different specialties: ER, surgeons, breast mammographers, ICU attendings, general hospitalists. We touch everybody.
Okay, that makes sense. And what kind of conditions would you say are treated most frequently at RUMC?
I'd like to bucketize them into 2, inpatients and outpatients, right? So for outpatient patients who are coming in, we do a lot of consultation for fibroids. For women have these benign tumor growths in the uterus, which are called fibroids.
Yeah.
And they cause pain, they cause excessive bleeding, they cause anemia. We treat a fair number of them. They usually are referred to us from their primary care physicians or from the OBGYN's office. We also treat a lot of trauma at RUMC. Obviously, those are part of inpatients. They come in through the ER. We do a lot of biopsies of patients, and we treat a lot of patients with oncologic abnormalities, cancer. Liver tumors, kidney tumors, like I described before, lung tumors, we treat a lot of that. So we have a lot of need for interventions, and I think RUMC is well poised to provide that need to our patient population in Staten Island.
Absolutely. And there have been rising cancer levels, especially here. So
Staten Island, unfortunately, has the dubious distinction of having some of the highest cancer rates in New York State and New York City. Of the 5 boroughs, Staten Island has the highest cancer rates in breast cancer, prostate cancer, thyroid cancer, and it has almost confused the epidemiologists as to why this is the case. This is the reality, and I think RUMC can provide the treatment to our patients in Staten Island.
Absolutely. I know there's a lot of different beliefs about that. Some people, I think, believe that because we are a slightly more residential borough that people go for more screenings, and that's why we could potentially have a higher number of cases.
Access to screenings is something that's very near and dear to my heart.
Yeah.
I think there should be access to screening. Screening leads to earlier detection of cancer. Early detection of cancer leads to better treatment or better patient outcome. I spoke about one kind of cancer screening, which is the lung cancer screening. And, patients have to meet certain criteria for lung cancer screeners to be performed at generally. And RUMC provides that platform for patients to come and take advantage of. The other thing is breast. Breast cancer screening has shown in many, many literature to be very effective in providing cure. The earlier the detection, the faster the cure, the better the patient outcome.
Yes.
So these are very important. Access to colorectal screening, colonoscopies more than the age of 50 for men. Has to be provided access to our patients, and RUMC has the capability of dealing with all of this. And these are easier. Screening is done for cancers that can be treated.
Yeah.
And it's not done for all cancers, obviously, but it's done for cancers that can be treated and cancers that, if treated earlier, can provide better patient outcomes. So it's important to get access to those screening protocols, and I would encourage our listeners to think about getting screened for all these tumors.
Do they use interventional radiology for any of the skin cancers?
So skin cancers we do less of,
Yeah.
but let's say, for instance, let's take melanoma, for instance. Melanoma tends to be a very insidious cancer, and it can metastasize very quickly. Again, one of those things, if you see a little growth in your skin, at least the visible part, and if you see that it's irregular, it's red, it's a little indurated, that means it's a little irregular in its surface and feel. If you feel that it's bleeding a little bit, it keeps on itching, and it's growing in size. These are all sort of ominous signs. Go see your dermatologist or see your local physician, and they will decide to maybe do a biopsy. Most of the skin lesions are biopsied by dermatologists. But then again, if there is unfortunate metastases to different organs in the body, then interventional radiologists, they get involved in biopsies and further treatment.
Got it. Okay. And can you walk us through what an initial visit is like when a patient comes in for interventional radiology? What do you go over with them in that visit?
Right. So let's take the example of a woman who's suffering from fibroid disease and who's coming in with what we call symptomatic fibroid disease.
Yep.
You come in, you meet the attending interventional radiologist, and we go over what's bothering you. We go over your past history, your past surgical history, your past medical history, your allergies, what we call review of systems. That means in the last 6 months or so, have you felt a little different? Any unexplained fevers, any unexplained weight loss? And then we understand from you the actual symptoms that's bothering you. And then we describe alternatives to alternative treatments for all of these symptoms. Generally, for fibroid disease, if you're coming to see me, I'll give you 4 choices.
Okay.
One choice is not to do anything. That's always a choice. Number 2 is using medications. Number 3 is surgery. And number 4, what we interventional radiologists do is uterine fibroid embolization. And without getting into the details of the procedure, the overall discussion, is between the physician and the patient in describing the procedure, describing the benefits of the procedure, and describing the risks of the procedure. Every procedure has risks, and including this one, it has much less risk than, let's say, open surgery, but it also has the benefits that are little muted based on, if you do surgery for fibroid, surgery means taking the uterus out. If you take the uterus out, obviously the symptoms go away. It goes from 100 to 0. In other cases, in this case, the symptoms don't go away fully, but they decrease to the extent that it doesn't bother you anymore.
Yeah.
But then you have to take that in under the context of surgery has much more risks and long-term risks versus here in uterine fibroid embolizations, the risks are much less. But that's a decision that the patient has to make based on a full set of risks and benefits discussion that we've had before. So that's what you should expect for any condition that you're coming to meet an interventional radiology, or for that matter, any discipline for that matter.
And so say a patient did decide to go the interventional radiology route. What is the recovery time typically from going that route?
So uterine fibroid embolizations usually happen on an outpatient basis. You come in the morning around 6:30, 7 o'clock. We bring you in because we give you some IV hydration. The procedure starts around 8 o'clock, 8:30. Procedure takes about 2 hours. You're done around 10:30. And we keep you within our department for about 4 hours after that. Okay, we get access into the uterine artery via the right groin or the left wrist. In either case, we want to make sure that there is no bleeding complications and you are recovering well and there is no pain or less pain. If there is excessive pain, then worst comes to worst, you might have to stay overnight. But of the 12 or so years I've been doing this, I have probably admitted one patient.
Okay.
Most patients go home the same day and you're ready to go home by 3 or 4 o'clock that afternoon. The recovery period beyond that is about a week.
Okay.
You will get what is called a post-embolization syndrome, which is basically feeling fatigued, having a feeling of malaise, and having a light fever. That lasts for about 24 to 48 hours, and then you should be on the mend beyond that. By 1 week, you should be completely back to baseline.
Okay.
Not so the case in surgery, in which case
longer.
it's about 6 to 8 weeks.
Wow, okay.
It depends what the patient wants and if the size of the uterus and the number of fibroids. In some cases, surgery is the right approach.
Okay.
So that's a discussion we have when we meet.
Yeah. I mean, it definitely sounds like it would be less recovery time for a better option if you could avoid surgery to go that route. Definitely.
If you can avoid surgery, that's the right thing, but sometimes you cannot. Sometimes surgery is right and the better approach.
Okay. Do you ever find that people have misconceptions about radiology? Are there any myths that you kind of find yourself having to dispel that patients might come in with?
People have all sorts of misconceptions.
Yeah.
I think there is a lack of understanding of what interventional radiology is. My parents did not know what interventional radiology is, and I told them I'm going into interventional radiology. They're like, what is that?
Yeah.
Because people know about cardiologists, people know about neurologists, internal medicine doctors. Not many people know what interventional radiology is. It's actually one of the reasons I went into it, so that I can experience it and then I can make people understand that we do very good work with good outcomes and it's minimally invasive. This specialty has been around for 50 years or more.
Yeah.
We are the specialty that started the cardiac catheterization way back in the 1960s and 70s.
Okay.
It started by Dr. Daughter at the Daughter Institute. And we have been around for a long time. We have been, innovating and creating new procedures for a long time. And we continue to do so.
That's wonderful. Yes. And now, would you say that there are, any major risks associated with interventional radiology?
Yeah, there's always risks to every procedure. However, is the sort of minimally invasive nature of that procedure, there's always risk. There's always a risk of infection. Whenever you introduce something from outside the body to inside the body, there's a risk of infection. There's a risk of organ injury. There is a risk of bleeding. When we do something in the liver, we are crossing, let's say we're doing a liver biopsy, then we are crossing multiple veins, multiple arteries. They bleed. The overwhelming majority of the time, the bleeding stops on its own. The body has its own mechanisms to stop bleeding because these are very small veins and arteries. In some small percentage of patients, it doesn't stop on its own. But then, we have to intervene. Again, we intervene in a minimally invasive manner. In a very minuscule percentage of patients, if we are unable to manage that risk of bleeding, then we send it to the surgeons. But again, we are talking about overwhelming, like 95 and more percentage of people, they do well.
That's totally fine.
They do well. They come in the morning, and they go home in a few hours, completely pain-free.
That's great, and it's wonderful that people don't have to leave the island for those type of services. They can get them right here at RUMC.
They can get them right here at RUMC. They can come in. Again, like I said, we have extremely well-trained, board-certified physicians who are here, ready to help, and eager to build a practice here at RUMC.
That's great. How would you say that interventional radiology is different today from 20 years ago? What are some of the advances in technology and things that you've seen?
One of the reasons I went into interventional radiology is because I like technology. I like to play with new tools. Interventional radiology is, and pardon the extrapolation of this, and it's kind of like flying a fighter jet.
Okay.
You are maneuvering this very expensive multi-million-dollar equipment, but you're doing it for the good of mankind. You're doing it for the good of community. You're serving other people. And the technology keeps on growing every single day. Every day or every month or every year, there is a new catheter, a new wire, a new technology that helps the patient even more so, kills the tumor cells even more so, sends the patients home with even less pain. The recovery time is even less and less. And back in the day when fibroid embolization started, the recovery time was more. And now we are so precise in our delivery of treatment that the recovery time is less, the pain is less. We have learned from our experience back in the day, from what to do. Like everything else, technology has improved, and so has patient outcomes.
Yeah, that's great. Now, what made you choose to pursue a career in medicine? Was it because you were interested in radiology from the beginning, or?
So actually, my wife did. She's the torchbearer in our family. She was the physician first.
Okay.
And I found myself more interested in her books than mine. I was actually working in corporations, in operations and finance before I decided to move to medical school.
Very good.
When I was 28.
Okay.
And since then, because I was involved in technology, I like technology. I like to play with new toys. And I decided to move into radiology and then interventional radiology.
Okay. And what do you like to do in your spare time to decompress?
Oh, I can't decompress. I have a 17-year-old daughter who is applying to college, so it's always very stressful at home. And I play tennis.
Okay.
I bike a lot. My wife and I travel a lot, so that's what we do.
Very nice, very nice. And what type of medicine did you say that your wife practices?
She's a pain management doctor. Yes.
Okay.
She has her own private office in New Jersey.
Nice. That's very good. And what would you say has been the most challenging case that you've worked on?
Technical challenges aside, I think more challenging and I think more rewarding for me personally is my interactions with patients. A challenging case is where I am not able to deliver to the patient what I promised. And I'm very careful as to what I promise. I'm very pragmatic in my approach to medicine. All my patients And I think I'm a little too pragmatic with my own family. But I don't sugarcoat things. I lay it down as I think is best for the patient. And I explain to the patient that there are no miraculous cures out there. We will try our best. And here are the options that we have in front of us. Here are the risks, here are the benefits. But I struggle most when I'm not delivering to the patient what I promised. And so whenever there's a patient who's come back and says, "Doc, I'm not getting the results that I wanted," that's where I struggle most. And those are challenging, and I take them personally because I feel a personal sense of responsibility towards my patients. My challenge is to make sure that my patients do the best. In not only standard of care, they should exceed standard of care. And I think RUMC, as a hospital, and the doctors in RUMC, I think all of them provide that. And I'm new to RUMC, and I can see that happening. We really strive to provide the best that we can to our patients.
Absolutely, and we're lucky to have you. So I'd like to thank you once again for joining us today.
Thank you very much.
We are grateful for all that you do to keep us safe and healthy. If people would like more information about our interventional radiology services, or if they'd like to schedule a consultation, they can do so by calling 718-818-3280 or by visiting rumcsi.org. Thanks again for joining us. I'm Meredith Gaskins.